Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have here a patient who attended with bilateral, fully occluding earwax, and I'm just commencing with this there right ear first, which is the worst one out of the two. As you may have seen, the entrance of the ear canal is extremely narrow, and this patient's got really soft and sticky glutinous earwax, which can be quite problematic to suction sometimes. Just for that reason, you may have seen there, the suction probe got blocked. So as the wax was trying to travel up the tube, it blocked the inside cavity. Fortunately, on that occasion, I just gave it a little wriggle and the wax started to travel up the tube again. So this patient has got also a lot of dead skin. You can see that here, and this skin is very moist and damp. Upon further questioning, the patient did advise that they try to flush their ears out themselves using over-the-counter DIY bulb syringe. The problem with water in your ear is that not only can it cause an ear infection called swimmer's ear, but it also causes the skin to become very damp and moist and macerated. So skin is hydrophilic, it's water attracting. So dead skin cells and the outer layer of the skin that lines the ear canal, the epidermis layer, they absorb moisture and water. And if you have too much moisture and water that gets absorbed, the skin cells become overhydrated, which then causes the skin to become soft, macerated, and it can also then burst the membrane. So it can break up dead skin, causing it to be very mushy in consistency. So I'm just trying to tease this out of the entrance. So this plug of wax and macerated dead skin is larger than the patient's ear canal entrance. I'm having to wriggle and squeeze this through. Where we're at now is a region of the ear called the isthmus. The isthmus is the region in between the first and second bends of the ear canal. So our ears are not straight cylindrical tubes. They are oval in shape and they have an S-bend configuration. As we enter the ear, about 1/2 centimetre in, we have the first bend of the ear canal, and then about a further 1/2 centimetre to a centimetre away, we have the second bend. So the ear canal's got a meander near the entrance. Beyond the second bend, the ear canal's more or less straight, although it can narrow and widen and kind of incline upwards slightly. Our ears have got a natural inclination upwards around 32 degrees. And the S-bend configuration of the ear is believed to be an evolutionary advantage, benefit. It prevents objects that may enter the ear to directly penetrate through the eardrum. So if you have a foreign body that enters the ear, for example, a twig, that's going to have to mitigate and navigate the first and second bend before it can do any damage to the eardrum. So it's more of a protective mechanism one would have thought if it's due to evolution. As you can see, I'm just managing to squeeze this through. It's almost like giving birth to this wax plug. And this is now right at the entrance of the first bend. And I'm just going superiorly to the roof of the ear canal just to bring this down and away. And there we are. I'm going to re-enter the patient's ear. You can just see how narrow and bendy this ear is. That's the patient's eardrum. It's nice and healthy. We've got a good light reflex there. I'm just going to mop up near the entrance. It's just a bit of soft wax and skin. I did put a lot of olive oil drops in here to change the consistency to help me to vacuum this out of the ear. And then in a moment we're going to switch over to the left ear now. The left ear, this is their patient's left ear. It's not fully occluding, I would say it's semi-occluding. And so not only is there less wax, but this ear isn't as narrow, particularly the entrance. They do have a bendy, twisty ear canal here. So I'm just using the microsuction tube here, and we're quite lateral. So when we say lateral, we mean near the entrance. And I'm just lifting this sticky wax off the canal wall. See, there's quite a few cilia there, hair strands. So these hairs should only be located near the entrance. in the outer third of the ear canal. The outer third of the ear canal, the cartilaginous region, the skin that lines the cartilage, it's got three layers. You've got your epidermis, and you've got your dermis, and then you've got your subcutaneous layer. And it's in the dermis layer, so the middle layer is where you normally find the hair follicles. And for that reason, you shouldn't find any hairs in the inner two-thirds, the bony part of the ear canal, because the bony part of the ear canal only has the outer layer of skin, the epidermis. It doesn't have a dermis or subcutaneous layer. So therefore, it's impossible for any hair strands or hair follicles to form on the bony part of the ear canal in the absence of the dermis layer of skin. The eardrum's already visible. I'm just mopping up some of this sticky wax near the entrance. And again, a nice healthy eardrum, just having a good examination of that. The patient could hear significantly better. Post-procedure, their hearing had substantially improved, and they were also suffering from tinnitus, which is a ringing or a buzz, or any type of sound that originates within the ears or head. I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.